So let us begin the session. So what exactly is pain? So a brush up of this, the few of the points which we discussed in the last session. So the International Association for the Study of Pain, that is the IASP, has defined pain as an unpleasant and sensory and emotional experience associated with actual or potential damage or described in terms of such damage. So this is the standard definition which has been given by the IASP. Talking about the basic and the classification of pain, again it is divided and again classified on the basis of duration, cause, and mechanism. So talking about duration type of classification, it is further subdivided into acute, chronic, and acute on chronic. And based on the cause, can be a cancerous or a non-cancerous cause. And talking about the mechanism classification, nociceptive, that is physiological, and neuropathic, that is pathological. So we have discussed in detail about this classification in the last session also. Again, classification of acute pain. So as we all have discussed also, and as we all know that again, types of pain, acute and chronic. So acute pain is further divided into somatic, somaesthetic, and visceral, that originates from the viscera. So example can be angina pectoris, peptic ulcer, intestinal colic, renal colic, or etc. Talking further differentiation of the somatic type of pain, it can arise either from superficial, that is from the skin and subcutaneous tissue, or it arises from deep, that is from the muscle, bones, fascia, or periosteum. So from the skin and superficial subcutaneous tissue, that is, when you have a superficial burn or some cut is there, then the type of pain which you experience during that time, that arises from the superficial, which is a type of somatic type of acute pain. Again, the second type is deep, and it arises from the deep structures, from the muscle, tendons, fascia, especially you see in fibrositis, arthritis, or after a RTA, when you have encounter or you have a fracture, or whether there is a rupture of the muscle belly. So that type of pain arises from the deeper structures, and again it is a subtype of somatic type of pain. Some of the brief differentiations of the acute and chronic pains. So again, as by the name suggests, acute versus chronic. So acute is definitely sudden, short duration, and it resolves and disappears when the tissue heals. But again, on the other hand, when you talk about the chronic type of pain, it is insidious. That is it has a slow onset of action, and the pain can even remain even when the tissue healing has been done. So it mostly persists for a long time, especially you see that, a knee inflammation or arthritis or arthritic type of, so that type of pain becomes a chronic type of pain, and it persists even when the underlying structures are being healed. So what exactly is the signal for this acute pain? So warning sign of acute, warning sign of actual or potential tissue damage. But in chronic, it is not a warning signal or damage or falls around. Talking in terms of severity, the acute pain correlates with the amount of damage, while on the other hand, chronic pain severity doesn't correlate with the damage. CNS involvement, yes, CNS remains intact, and acute pain is a symptom. Again, CNS may become dysfunctional, and chronic pain is a disease. So you see the basic difference, that it is a symptom, and while on the other hand, chronic pain, whether there is dysfunctioning of the central nervous system, it becomes more or less of a disease. Psychological impact, yes, in case of acute pain, it will have a psychological impact, but in terms of chronic pain, it will have a less as compared to this. So it can be followed by anxiety, sleeplessness, again, some type of unrelieved pain may be accompanied by these symptoms. While on the other hand, when you talk about the chronic pain, it can, may lead the patient to develop, depression. There may be fear, social withdrawal, anger. So all type of, because, it persists for a longer duration and for maybe up to months or years or maybe up to lifetime. So this is again, it becomes, very difficult for the patient to remain psychologically alert, and it has a very, strong impact of psychological dysfunction on the brain. So neuropathic pain, so as by the name suggests, that is caused by a lesion or disease of the somatosensory system, that is the peripheral nervous system or a central nervous system. Peripheral nerve, whether it can be due to diabetes mellitus or a carpal tunnel syndrome, post-herpetic neuralgia, or traumatic brachial plexus injury. While on the other hand, when you see the central nervous system causes, it can be a post-stroke pain or neuropathic pain, which is associated with a spinal cord injury or trauma. So again, what exactly is this mechanism of neuropathic pain? So what exactly is happened? So whether it has, whether it can be either due to peripheral nerve or central nerve, either due to a PNS or CNS involvement, there is nerve damage, yes, and there is persistent stimulation of that nerves. So because of that persistent stimulation, because is going on, because of this causative factor which is there is rewiring of pain circuits, which we'll be discussing in the further slides. What exactly are these circuits? So these circuits, they rewire, they readjust themselves both biochemically and anatomically. So because of that readjustment, rewiring, it leads to either a spontaneous nerve stimulation or a autonomic neural stimulation or increase in discharge of dorsal horn neurons of the spinal cord, and which finally leads to the causing of neuropathic pain, which is exactly the positive thing. So when you differentiate nociceptive versus neuropathic pain, so nociceptive pain is well localized, while on the other hand, the neuropathic pain is not well localized. Nociceptive is sharp and it becomes worse with movement, but again, neuropathic can cause you a burning sensation, shooting, some pins and needle type of pricking sensation, and it may also be accompanied by numbness. And especially if you encounter a patient of diabetes mellitus who is uncontrolled, which having uncontrolled sugar levels, so mostly they develop this, numbness, pins and needle, pricking type of sensations. Obviously, obvious tissue injury or illness, nociceptive pain, and in neuropathic, tissue injury may not be obvious. So, so nociceptive pain is accompanied by inflammation, while on the other hand, neuropathic pain leads to nerve injury, changes in wiring, abnormal firing, and loss of modulation. Why? Because there is this mechanism which is being going on. Either there is a spontaneous nerve stimulation, or there is more of discharge from the dorsal horn neurons, or autonomic neural stimulation. So nociceptive pain is a physiological, while on the other hand, neuropathic is a pathological. And this is again one of the important differentiating factor between the two types of pain. Now, what exactly is this referred pain? So we all must have, some or the other time, if you are practicing, if you are a palliative care expert, if you are, specialized in, medical field, or you are encountering a patient, any of maybe medical or surgical, any background, so he or she, or maybe the point of origin of the pain may be different, but there may be a referred pain at some other site. So why exactly this thing is happening? So pain that is perceived at the site different from its point of origin, important. But why exactly is this happening? Because they both are innervated by the same spinal segment. So it usually applies to the pain that originates from the viscera. Example, the pain of a myocardial infarction, you see that the patient usually complain that the pain is radiating maybe to the left arm, to the chest or neck. So referred pain is a pain from one location, mostly from the internal organ, that is felt in another location, often where on the skin or muscles. So there is a very famous theory which is being associated with this referred pain, that is the convergence theory. So this type of referred pain occurs because both, that is the visceral and somatic efferents, often converge on the same interneurons in the pain pathway. So if you look at the diagram or the image which is being there, so there is convergence of this same interneurons in the pain pathways. So we refer the location of this visceral receptor activation to the somatic source, even though in the case of visceral pain. So the convergence of nociceptor input from the viscera and skin. So what exactly is this happening here? So this both, that is the visceral afferents, AFF, from the internal organs, and somatic afferents, they come from the skin and muscles. So visceral AFF comes from the internal organs, and somatic AFF afferents from the skin and muscle, they converge on the same interneurons, where they converge in the spinal cord pain pathway. So because of this common sharing of this pathway, the brain, which is the transformer, The brain cannot distinguish whether the signal is coming from the skin or muscle or from the organ. So brain becomes confused. So because of this, the brain refers the pain to a somatic skin or muscle, because the somatic pain is coming from the skin or muscle. So the brain then refers back the pain even though the real origin of pain is from the visceral. So because of this brain getting confused, because of this, wiring of the system, even if the source of origin of the pain is from the visceral, the brain refers it to a somatic. So that's what it is happening. So a myocardial pain, the brain doesn't distinguish. So it refers to pain maybe to the neck, chest, or maybe to the left arm. So the brain interception of the pain location is incorrect. So because of this brain incorrect perception, you call it as a referred pain. And this is important. So you see this, the most common. So the site of referred pain of the heart is seen at the left shoulder, arm, even of the esophagus, if you see, of the stomach and liver, gallbladder, appendix, colon, uterus. So these are the most common sites of referred pain which you encounter. So there are most commonly you see there are two theories which are being related to this referred pain, and you have to understand these two types of theory which are being associated with the referred pain. The first one is the convergence projection theory, and the second is convergence facilitation. Someone is facilitating. So we'll be discussing one by one. So what exactly is this happening in convergence projection theory? So you see that is the visceral afferents, that is from the sympathetic fibers. Pain sensation that is coming from the visceral organs, they travel along the sympathetic afferent fibers. So these fibers then, they pass through the dorsal horn ganglion, and where exactly do they end? They end in the posterior horn of the spinal cord. So this is the visceral afferents, that is the sympathetic fibers. Then talking about the second part, that is the somatic afferents. So the pain signals that is coming from the skin or muscles, that is the somatic nerve, from the same dermatome also enter the spinal cord. And where do they enter? They enter at the same segment where the visceral afferents entered. So exactly they terminate on the same second order neuron where visceral fibers also end. So because of this convergence of these both visceral and somatic afferents on the same neuron, the brain becomes confused and it cannot distinguish. So the brain is more accustomed to receiving signals from the skin and muscles rather than internal organs, because you see your skin gets cut maybe more frequently, you have a muscle strain, muscle pain, even muscle tear or so while working out or so. So your brain is more used to this superficial, that is skin and muscle pain. So because of this, the even if the pain is originating from the internal organs like heart, it projects the pain to the somatic regions like the skin and muscle instead of the actual organ. So this is the convergence. Because of this converging at the second neuron, second order interneuron of this both visceral afferents and somatic afferent, the projection of this brain is to the somatic. So it is known as convergence projection theory. I hope I am very clear, and it is a very beautiful theory. And because through the name only, you can easily distinguish that what exactly is this theory is trying to portray. Now coming to the convergence facilitation theory. So what exactly is this? So the pain from the deeper structures, again from the like viscera or deeper tissues, can facilitate or amplify the normal background activity of the spinal neurons. How? Now you see second order neurons are there in the spinal cord. These neurons, when they are at a resting phase, they have a low level of resting activity. And these are maintained by impulses which are coming from the superficial, that is the skin, cutaneous afferents, AFF. The second thing is the input from the deeper nociceptors, that is from the viscera or muscle. So when the deeper pain signals from the viscera enter, they increase or facilitate this second order or this second order neurons activity because at their resting phase. So because of this, the brain interprets this increased activity because they were at a resting phase, and now because of this pain signals which are coming, they are facilitating this. and they are increasing this activity of the second order neurons. So this brain interprets this increased activity as pain, which is coming from the cutaneous, that is the skin or muscle, that is originally coming from the visceral. So again, it sends back to the superficial. So if you club this talking, if you consolidate this both theory, the first is convergence theory, that is the visceral and somatic afferents share the same interneurons, that is the convergence theory. The second is convergence projection, that is the brain projects visceral pain to the somatic site due to convergence. The third is facilitation theory, in which visceral input amplifies the resting skin signals. Amplification is there, which is misperceived as a somatic pain. Now, what are this mechanism of pain? If you talk about this pain mechanism, as we know that pain sensation is a series of complex interventions between the peripheral nerves and CNS, and pain sensation is modulated by excitatory and inhibitory neurotransmitters, which are released in response to any stimuli. So they both comprise of four basic process. So if you also remember this four, even by the mnemonic, that is TTMP, or maybe transduction, transmission, modulation, and perception. So these are the four basics mechanisms, or you say the process of modulation.